whenever these advanced cancer patient comes with obstruction, there are three main things which comes in my mind. The first thing is that they already have adhesions. Second, they have disease recurrence, and the third is the patient has obstruction. So their main aim is to give the patient remaining life without pain. Sometimes relatives are also in denial mode and they still want to try 100%. They say, no, you do whatever, we want to do the stoma, or we want to go for open surgery also, or whatever you do, but just make sure that our patient might get some additional months.
Hello and warm welcome to MedSynapse podcast series, where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host Dr. Smarika Bhatt, and today we are tackling one of the most devastating situations in oncology when cancer has advanced beyond cure, leaving patients and their families facing the brutal reality of limited time and diminishing quality of life. But what if there was a better way to address these devastating complications? And today, to help us understand with this topic, today we have been joined by Dr. Kshitij Arun Manerikar, is a consultant oncosurgeon and minimal invasive laparoscopic surgeon at Galaxy Care Hospital. And he has enhanced his expertise with fellowship in surgical oncology and minimal access surgery. Currently, he is practicing both in Mumbai and Pune. Dr. Kshitij, welcome to the podcast. We are excited to have you here.
Thank you very much. Thank you.
Okay, without further ado, we'll start with our first question is, when evaluating the success of palliative laparoscopy, what quality of life matrix do you find best reflective its effective compared to traditional survival-based outcomes?
So first, when it comes to the palliative care or palliative patients, the health indexes or all matrices changes from routine patients, because when routine patient comes to us, our health matrices are different with respect to overall survival, prognosis, next 5 years survival or 3 years survival. But when it comes to the palliative patient, when we know that we are not going to completely cure the patients, but mainly it is for the palliation or decreasing the symptoms with respect to pain or obstructive symptoms or any other movements, we have to take care of these symptoms. So our main goal or main indexes to which we see is usually the symptoms with respect to pain. So if we can give any pain relief, then symptom with respect to the food intake, whether the patient is able to take the food and whether the patient is able to pass the stools, or whether we need to go for the stoma. So that is second indices. Then comes whether patient can be mobilized or patient can walk on his own, or with minimal support he can walk, or else patient is bedridden, because most of the times these palliative patients or these advanced cancer patients, they are already in terminal stage, they're very cachexic. Their health is so much deteriorated that they barely even sit or walk. So even this is one of the matrices we think that whether they can walk or they can sit for some time, they can at least do some of their own work. And then lastly, least talk, but one of the most important factor is the psychological well-being, because of the prolonged treatment, surgery, chemotherapy, radiation, or in combination of this multi-treatment, this patient and their relatives most of the times are exhausted, both physically as well as emotionally. So the psychological well-being is also very important, whether the patient is at least himself or herself wants to go for some palliative treatment, or he's absolutely in denial mode and they don't want to do anything. So we have to counsel them also with respect to that. So that's psychological well-being or psychological well-being point is also very important in these patients.
Okay, thank you so much, Dr. Kshitij, for addressing all those concerns. So we'll move on to the next question. When working with patients who have poor status and limited prognosis, how do we assess the risk-benefit ratio for laparoscopic diversion procedures?
So as these patients, they are terminally ill patients, they are in their advanced cancer stages. So the routine, what we see in routine patients with respect to physical status, their respiratory, cardiovascular status, what we routinely see for their performance, all those usually parameters doesn't work in these patients. We know that we are not going to have a normal proper patient. These are very asthenic patients, their BMI is very low, they're cachexic, they have hypoalbuminemia, they have hypoproteinemia. Most of the time, after seeing the patient and their condition, which cancer they have or which advanced cancer they are having, we know the expected life they have in the months, whatever, 1 month, 3 months, 6 months. So we have that. And then the symptom severity, what are the current issue. They have multiple issues, know that. Even patient and the relatives know that there is no treatment left which can be treated and which can actually completely cure the patient. But at the same time, the acute, that one particular or those particular group of symptom which is causing a patient issue, let's say sometimes is head and neck cancer patients, they actually have issue with respect to they cannot eat anything, they cannot have they have riles to or tube in the via nose by which we do the feeding. So they have that, so that actually they want to have some food in their last stage via mouth. Some of the patients in gastrointestinal cancers or rectal cancers in advanced stages, they are not able to pass flatus or pass stools or anything because they have obstruction symptoms. So in such patients, the pain in abdomen, continuous vomiting, ascites, these are the main their symptoms. So we need to see what are those group of symptoms which are currently actually causing discomfort to that patient, and which actually we can give them some relief regarding those symptoms. And then next set is we need to think in such patients with respect to family goal, what the family members they want, whether they have, there are different family goals actually. When such patients comes to us, many of the times these family members, they are already tried everything and they say we just want to now whatever months patient has, we want him to go pain free. So their main aim is to give the patient remaining life without pain. Sometimes relatives are also in denial mode and they still want to try 100%. They say, no, you do whatever, we want to do the stoma, or we want to go for open surgery also, or whatever you do, but just make sure that our patient might get some months, additional months. So you need to see the emotional well-being of their family member also, and what intentions they have. So these are the basically things.
That was really insightful, Dr. Kshitij. So, moving on to the next question, what objective criteria guide your selection of patients for minimally invasive palliative versus non-surgical management?
This is a very good question, because when such patient comes to us, as I said, they are 100% not fit. So it is not about whether these patients are fit or not. We know that is already inside our head that these are terminally ill or advanced cancer patients, third stage, fourth stage cancer patients. So they are not going to be fit. We want to see, or what I usually see is whatever bare minimal optimization if I can do in those patients. Bare minimal optimization in the sense of after hospital admission, many times we can at least give them TPN, we can give them albumin supplements, so that at least that hypoproteinemia situation causing anasarca, whole body swelling, lower limb swelling, and all these swellings can go. If we can give some nutritional and dietary supplements via, at least if patient is not able to take orally, can we put some riles tube and we can elevate the nutritional state of that patient. Or even if it is that not possible, then can we give some TPN, total parental nutrition, in a parental way, rather than giving orally. So these are also a thing. And with that, the next three main factors which comes in my mind is what is the first malignancy, that is what is the first cancer, whether it is a CA stomach, whether it is a CA colon, whether CA rectum, pancreas, or CA tongue, whatever. The first malignancy, what is that? Then the advancement of the diseases, since the duration of the advancement, the duration since the patient is being treated or not treated, and patient is in the advanced or ill last stage of the disease. The duration is very important. Many of these patients are a year or 2 years in head and neck cancers. They are been treated as a palliative. Sometimes in pancreas they don't survive so much, so they have hardly 1 month or 2 months. So that is also. And then comes the main point with respect to, if at all I am going to operate, what is the best possible, if that patient requires surgery with respect to alleviate the pain, with respect to giving relief from the obstruction, or with respect to if patient is having some perforation. So if I am going to operate that patient, one thing, if I am going to operate that patient, what will be the best possible method, whether it is open or laparoscopic. As you introduced me, I'm a oncosurgeon with advanced laparoscopic cancer surgeon. I have vast experience in laparoscopy, so my expertise is mainly doing the minimal invasive surgery. But see, when these advanced cancer patient comes, it is almost always important for me to judge whether these patients can undergo laparoscopic surgery, because in laparoscopic surgery there are some things which are different than open surgery. We have to put the ports, we need to see whether there enough space is there or not. We need to create the pneumoperitoneum. So as soon as we insufflate the abdomen with the pneumoperitoneum, there are tons of other changes which takes place with respect to our cardiovascular system and respiratory system. So because these patients are already nutritionally malnourished, so I usually see whether they can undergo any type of anesthesia, whether be it a spinal anesthesia or whole body general anesthesia, and then I assess whether they can be best candidate for the laparoscopic surgery or open surgery. Accordingly, I usually decide. And tentative disease progression, which comes in my mind, that if the patient is been treated for palliation since last 4 months, 6 months, then how much time that patient have. If I see patient is barely conscious, is drowsy, doing anything is not going to improve anything at all. I mean, I'm not going to add any days, weeks, but rather I will decrease by doing any morbid procedure. So I avoid doing all these procedures. So these are the all points which basically comes in my mind.
Okay, thank you for addressing those detailed differences. Moving on to more specific, more clinical scenarios, what is your laparoscopic approach in malignant ascites? And are there techniques that improve palliation over standard paracentesis?
So usually most of the GI malignancies, so whatever organs inside our abdomen, all will have ascites. At least sometime they are going to develop ascites, because if they develop the advanced cancer, so let's say if it is a CA ovary, CA colon, CA stomach, CA pancreas, or CA liver, they are going to have ascites today or tomorrow. Because of the disease progression and because of the poor nutritional status, that is mainly hypoalbuminemia and hypoproteinemia. So they are going to have ascites. With ascites, abdominal girth increases, so pain increases, and patient's breathing also gets hampered. So patient usually doesn't breathe normally. So these are the changes. So we need to usually tap, or we need to take the ascites. So there are multiple. So when first time I see such type of patient, I usually try to understand how many times these patients had been taken for ascitic tapping. That is, how many times prior to seeing me, how many times the ascitic fluid has been taken out of the abdomen. It's a local procedure, it's not a big thing. How many times? Many times every day, because there is certain amount. We don't take out the liquid 4 liter or 5 liter at a time. We take 1 liter or 1200 ml, because with the ascitic fluid, even nutritional things are also going. So patient loses their albumin, lose their electrolytes. We cannot take all the liquid at same stage. So how many times these patients prior had been done for the basically ascitic tapping, I see those factors also. After that, the another thing which I see is what will be the best method for this patient, whether this patient will be benefited from doing the laparoscopic procedures. So main source for these patients are omentectomy. So we usually I try to do the laparoscopic omentectomy in these patients, which will decrease the amount of the ascites. The same time, if I can do the omental biopsies, or I can take the peritoneal biopsies, if it is not done, most of them they are done because they are already advanced malignancies, so we don't need any this thing. But sometimes in conditions like malignant mesothelioma or when the patient is not diagnosed only, when directly presents in an advanced stage and advanced symptoms. So we prefer to put the drains in this patient, fenestrated drains, what we call usually. The same way what we put intra-abdominal catheters, the same way drains, so that at least every day we can clamp the drain. A certain amount of liquid we can allow that to drain from the body, and then again we can reclamp it. But again, for doing all this thing, the one thing that patient needs to at least be that settled that he or she can undergo the laparoscopic surgery. I feel it is very harsh to do the open surgery just to drain the ascites, because minimum if you're going to take this much or this much incision, but that incision is going to create too much problem for that patient who's already cachexic, already in pain. You're going to add more morbidity with respect to infection, sepsis and pain, and it's not going to help. So I try to do a laparoscopic ascites fluid drain in most of the patient whenever it is possible. If at all that is not possible and patient is not, then I prefer to do the ultrasound guided just tapping and putting the drain inside. So we put the pictal catheters. So again, via pictal catheter also we can do the quantified everyday drainage of the ascitic fluid.
Okay, thank you so much for sharing such a detailed clinical scenarios in surgeries. So before wrapping up our session, I'll ask you one last question. That is, which laparoscopic method have you found most effective for palpating bowel obstruction from peritoneal carcinomatosis while reducing hospital stay?
Yeah. So basically, whenever these advanced cancer patient comes with obstruction, there are three main things which comes in my mind. The first thing is that they already have adhesions, because they already had undergone some type of surgery, be it open surgery or laparoscopic surgery. Second, they have disease recurrence. So there is inside some studied with the disease, or some type of disease is there. And the third is the patient has obstruction, be it a small bowel or large bowel. So they have three issues: adhesions, recurrence of the disease, and with ascites and a bowel obstruction. So first, whenever such patient comes to me, first thing which I assess is the state of the patient. I know they are not going to be fit. They are already a hampered patient with respect to everything, physically, nutritionally, psychologically. But first I assess whether I can give some more months, or whether patient is in pain and in obstruction. If doing anything won't increase any morbidity or it won't cause any mortality, at least because of the surgical procedure, then only I take a next step that okay, we can do some surgery in this patient, whether if I'm going to create any stoma, be it ileostomy, colostomy, or some type of palliative gastrojejunostomy, or some resection anastomosis. That should not hamper patients' whatever life expectancy is there, month, 2 months, 3 months. So the procedure which should not increase any morbidity or mortality in a patient. Only and only after that only I give option to the relatives, because patient is not in condition to have any option. He's in pain or he's in obstruction. Third thing, if such patient is already in obstruction and already signs are perforation and sepsis is there, we don't have any option other than explaining the relatives it's a high risk patient, but we need to do a stoma as early as possible, and I usually go for the open surgery rather than going for the laparoscopic surgery. If patient is only in obstruction, there is no perforation, then I prefer to do the laparoscopic surgery, because in my mind, according to my personal opinion, any type of open surgery, be it a CA stomach with a gastric outlet obstruction, if I am going to do the palliative gastrojejunostomy, it should be laparoscopic, because if I am doing open, I am giving a scar, it is going to create more pain, it is going to cause some type of discomfort to the patient for next 4-5 days or whatever. So I don't want to do that. I want to do it in a best way, without pain or without added any additional pain. So I try to do laparoscopy. I do CT scan usually in all these patients just to see, because many of the times in whole abdomen completely bowel is adherent. And I try to see if I can find any window if window is there, I always use a trocar, optical trocar to go inside the abdomen after creating the pneumoperitoneum with the varies, and I look inside the abdomen to check where I can relieve the obstruction or I can take the stoma. Always in my mind, one thing is there that I need to go quick inside and quick outside without added any anesthesia time, which is definitely going to create more issues for that patient. So if it's ileostomy, I take ileostomy. If colostomy, then I do the colostomy. In a patients with the CA stomach or any small bowel obstruction where resection anastomosis is required, if that is the only option, then I do that resection anastomosis. I usually avoid doing any additional adhesiolysis. If the bowel is adherent to some places, I don't do any adhesiolysis other than which is must. If I need to take the ileostomy, and if it is adherent to the surrounding jejunal loops or large bowel, I will do adhesiolysis. But otherwise, I don't do any adhesiolysis because that is not going to that is not going to make any difference and not going to make any added benefits for the patient. And with respect to creating other stomas, it's only, I think so, in the cases of CA stomach palliative, whether we know that the patient is in gastric outlet obstruction. In those patients also, I prefer to the laparoscopic gastrojejunostomy. Even if that is not possible, then I go for the peg tube. At least of sometimes we only need to do the feeding jejunostomy, so better to do the peg rather than doing the feeding jejunostomy. So uses of laparoscopy is best when it mainly in a palliative care for the GI patients, because at least it doesn't create any more scar, it doesn't give more incision pain and more added chances of infection and sepsis. So the laparoscopy is the best for the palliation, but provided the patient in already decompensated patient, that patient should be bare minimally fit for at least going for that laparoscopic surgery. If the patient is not bare minimally fit, also is always better to do the open surgery. And primary aim for me is to elevate the pain, elevate the obstruction. If perforation is there, then we need to take out the stoma. So whatever amount of lifespan that patient is having, that should be at least with the least possible pain. Patient should eat orally. That is my primary intention, because these are the last days or months for the patient. So at least they should have whatever they want to eat. They should take orally. That is my second goal. And they should pass stools not from the natural passage, but at least via stoma, so they can eat and they will come. So at least they won't have an abdominal distension, which will cause discomfort, then pain, then breathing difficulty, and it vicious circle goes on. So these are my main things. So watch for the signs. My final verdict for everyone is, according to my experience, is that choose the patient wisely. Choose what their goal, what their psychological burden and psychological relief is there at that moment. If the patient expectancy is anywhere between 2 to 6 months or year, maybe anything between more than 2 months, you should do something for that patient. Anything less than 2 months, I think so it's best way not to do anything. You just give total parental nutrition or albumin or any type of parental nutritional supplements, rather than going for the any radical or any minimal invasive surgeries also in these patients. And whenever it is not possible, then always go for the open surgery. Even if you are doing laparoscopic surgery, always do the CT scan, check for the adhesions of the bowel, because it tend to be the adhesions will be there. So choose wisely the window where you can put your varies, window where you can put 10 number of ports. It is still better than having the one midline large laparotomy incision for these patients at least. So it's always better.
Okay, thank you so much, Dr. Shakash, for sharing such knowledgeable experience with us. I'm sure our audience will get a great benefit out of it. And thank you to our viewers for tuning in. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate us to join on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay healthy, take care. you.